we'd like to thank you very much for joining us today. You're watching the People's Channel, WCCA TV, Channel 13. And we're very lucky to have Joy with us from the Senior Companion Program. And RSVP and Senior Companion are part of the Family Services of Central Mass on Harvard Street. And Joy, I'll pass it over to you.
Hi. Good afternoon, ladies and gentlemen. Today we have Dr. Donald Pelto here to do show you a diabetic foot assessment.
Thank you so much. Thank you. My name is Dr. Donald Pelto. I work here in Worcester. And the first handout you have is a handout that talks about fall prevention, because that's just what the last talk you had about was. But what we're going to do today is we're going to talk a little bit about the complications of diabetes especially in your feet. So what I'm going to do is I'm going to show you with this little piece of paper with the blue on top. It's going to explain exactly how to do a diabetic foot exam. What are the steps that need to happen in this exam, and so how you can do it on someone else. And I'm going to actually show you with a volunteer here today. Okay? But I also want to tell you a little bit about the handout that you're seeing, just to give you a little orientation to the handout. So it's called the Comprehensive Diabetic Foot Exam. So the reason a lot of people are saying 3 months is because most people with diabetes are seen by a podiatrist every 3 months to trim their toenails. Trim their toenails, trim their calluses, and then if they have a sore on their foot or a wound, they may need to be seen more frequently. Okay? But this type of an exam, this depth of an exam, you only do it about every once a year, or a little bit more frequently as needed. So we're going to go through this today. Plus everything else. There's a lot of foot problems that people can have with diabetes. What's the worst problem that can happen if you have diabetes for your feet? What's your thoughts? A loss of a toe or amputation. That can happen. And I have a lot of people that come and they say, Dr. Pelto, I have diabetes. I've only had it for a few months. Am I going to get an amputation? That's what everyone's fearful of. But what I tell people is, being fearful of an amputation, you don't have to be fearful of an amputation, as long as you don't have the risk factors that can lead to an amputation. And that's what this exam is for. It's to look for the risk factors that can lead to an amputation. The two most important ones, lack of blood flow, if you have poor blood flow to your feet, and lack of feeling. And that's called neuropathy. And we're going to get to that in this exam. So to begin with, I need someone to help me here. Who can help me? This is a general foot exam, but it's more specific to people with diabetes.
All right.
That's correct. So there's a lot of different types of neuropathy. Is a very big term. Neuro means nerve. Pathy means injury. So what can happen with your nerves with diabetes, I kind of equate it to a light bulb. If you think about a light bulb, initially it's nice and strong, but what happens to a light bulb when it goes out like this? Before it goes out, what happens? It starts to flicker. And that's the same thing with neuropathy in your feet. Before the neuropathy goes out completely and there's no pain, you start to have a lot of painful signals going down there. And then eventually, if the neuropathy gets bad enough, it stops and there's no pain. And there's no feeling. And that can actually affect your balance. So come on up here, my volunteer. Let's give her a round of applause. What's your name? This is Diane. So Diane's going to be my patient. Diane, do you have diabetes? Diane, you have to imagine that you have diabetes for this exam. Okay? And everyone can follow along. And I'm going to fill this out just like as I would with another patient. Okay? So Diane, we're going to begin on, there's 2 pages. Can everyone see the second page? And for those on the TV, I'll give you a copy so you can put a copy up for afterwards. So the front side says Comprehensive Diabetic Foot Exam. Diane. Now, I'm going to start this exam, and I'm going to have to look at your feet. So I'm going to have you take your shoes and your socks off and put your feet up here for me. But before, I'm going to ask you a few questions. Who do you see? Who's your primary care doctor?
Dr. Ronald Doris.
Dr. Doris. So it's always important for me to know the primary care doctor. Do you know why? If I have to call them, if there's a problem, if there's a sore, you always have to know who their primary care doctor is. That's why it's very important to keep that list. If you can't remember them all, you have to keep a list of them. Okay, Diane? When was the last time you saw Dr. Doris? Monday. So then I put the day. Very good. Why do I ask when was the last time they saw them? Because a lot of patients that have diabetes, sometimes they haven't seen their doctor for a year or two. So the diabetes might not be under control. So we have to know if the diabetes is under control and if they're being followed by a primary care doctor. And sometimes it's not a primary care doctor. There's another specialist that sometimes people with diabetes sees. Anyone know what that's called? An endocrinologist. An endocrinologist or a diabetes doctor. So a lot of times, if you have your primary care doctor, and then you have an endocrinologist as well. Do you have an endocrinologist? You have a pulmonologist. And what was your last blood sugar?
Fasting or AC?
Wow, she knows both terms. How about the fasting one? 100. So where it says FBS on the right-hand side, it was 100. And then when was that done for you? You can just guess.
About June.
About June? And your last A1C, what number was that?
5.7.
5.7. I have a perfect patient in Diane. She actually knows her numbers. How many people with diabetes know your last blood sugar? Raise your hand. Good, you know your last blood sugar. Who all knows their last A1C? Never heard of an A1C. When you go to your doctor, say, please tell me what my A1C is. I'll explain what an A1C is. I always call it the Lie-Detector Test. You know why?
Yes.
Because it tells if they're lying.
You can tell the doctor anything.
You can tell me a lie about the fasting blood sugar. Let's say her fasting blood sugar was 100. Okay, 120 is normal, it's 100. But what happens if she tells me her A1C was 12? Either she's really, really low today, or she's maybe doesn't really know. Because an A1C should be around what number? Who knows the number that an A1C should be?
Low 7.
Good. Low 7. You win one of my prizes. Good job. Okay, so I have a few prizes here if you answer the right question. So a number 7 is the correct number for the hemoglobin A1C. So yours is 5.7. Is that good or bad? It's good. It's good. It's under 7, so it's a very good number. If she had a number 10 or 12, that would be high. You think maybe I would call the primary care doctor?
No, you don't.
I would call the primary care doctor just to make sure that something is under control. And the reason is because if the blood sugar is very high, it can affect a few things. It can affect your eyes. You can get that retinopathy stuff. It can affect your nerves. You can get neuropathy. It can affect your kidneys, and you can have kidney problems. So having elevated blood sugar over a long period of time can affect your body. That's why I ask these questions. Do you have any allergies?
Yes. Seasonal and food allergies.
Okay. Seasonal and food allergies. And just give me one of the medicine allergies. Sulfa drugs. Why is that important?
So that you won't get over it.
So I won't give her those medications. But how about if she has a foot infection? I may have to give her an antibiotic. And I want to make sure she doesn't have an allergy to that antibiotic. Because there's a lot you can choose from. So if she has a sulfa allergy, I want to avoid a medication that has sulfa. That's why it's so intense when we ask these questions. Just, you can make up a number. How long have you had diabetes?
5 years.
5 years. Why is that question important? If she's had diabetes only 1 year, do you think she has more symptoms or less symptoms?
Less.
Hopefully she has less symptoms. If she's had diabetes for 30 years, more symptoms. So I might expect to see more complications when I look at her feet. Do you understand why you need to know the amount of time? Now, there's one caveat here. If she only has diabetes for 1 year, but she never was diagnosed for 3 years, maybe she's had it for 5 years, but it was only diagnosed for 1 year, so that means her blood sugar was out of control for 4 years. She may have advanced very quickly with her symptoms. So it's very important that we know that. I don't know if you know this, but there might be a few people here that have diabetes, but you don't know it. There's a lot of people that go what we call undiagnosed with their diabetes. Did you know that? So if you feel some of the symptoms, that if you feel kind of lightheaded, if you kind of have ups and downs when you eat, if you feel kind of sweaty or jittery or lethargic or lack of energy, ask your doctor. They may need to check your blood sugar level because you may not know it. Very, very common. Okay, now we're going to go to the left side of the paper. And there's a big word. It says what office is doing the clinic. Well, I'm going to put my office. This is my office, Dr. Pelto's office. Last palliative care visit. That means the last time you were seen by for the foot care. 2 years ago. So she didn't see me for 2 years, but some of you, for palliative care, that means when's the last time you had your calluses trimmed and your nails trimmed? For some people, that's every 2 months. Some people, it's every 3 months, every 6 months. It depends on the patient. In my office, typically it's every 2 or 3 months that people have the nails trimmed and calluses trimmed. Okay? Now I ask past medical history. Now, when you see someone with diabetes, it usually means they have a couple of other diseases. What other diseases do you think are pretty common with people with diabetes? Raise your hand. Your eyes, maybe some retinopathy. What else? High blood pressure. What other ones? High cholesterol. Ulcers or a foot sore. What other ones do you think are common?
Cardiac issues.
Some heart issues or cardiac issues?
Anemia.
Maybe anemia. Leg swelling, edema.
Whatever.
Yep, leg swelling. Those, you're very, very right. And the way I kind of explain it to patients is that diabetes is kind of like, have you ever seen an iceberg in the water? When you look at an iceberg, you only see the top of the iceberg. But usually there's 3 times the problem underneath it. And that's how diabetes is. You only see when someone says, oh, I have diabetes. Well, you don't see all the other stuff that's underneath it, all the other health conditions. And that's especially true if someone has a sore on their foot or something called a diabetic ulcer. If they have a sore on their foot, it probably is speaking to a lot of other health conditions that you're not seeing. Very important to notice if there's any sores in the foot. So for your, what other medical conditions do you have?
I had cancer.
Cancer.
I had a lung injury.
Lung injury. Any high blood pressure? No? Any high cholesterol? Not now. Perfect. And just give me a few of the medications you're taking. You're very easy. What are some of the common medications that diabetics would take? Raise your hand. Metformin. Genovia, Glybride. Yep. What other medications? The statin drugs. So those would be more for heart issues. They may take a lot of other types of medications. Why is it important for me to know? Well, if someone has diabetes, but they're not taking any medications like my patient Diane, what does that mean?
She's watching her diet.
Correct. She's watching her diet and she's exercising. Did you know you can control diabetes with diet and exercise? Yeah. That's usually the first stage. The second stage, the first kind of medication they normally put on is metformin. That's usually the first medication, and then from there it can be transferred to other ones. And then a lot of people need Actos as one. Actos. Then as they advance, then maybe they have to be put on insulin or other types of medications like that. Okay? Insulin does a very good job at stabilizing the blood sugar. Now, about your feet, do you have any complaints? Do you have any foot problems?
I think 2 years ago I dropped something on my feet, my toes, I broke the toenails, and I injured a nerve.
Injured a nerve? Okay. And how about today? Any foot problems? No. What are some common foot problems that diabetics may have when they have an exam like this? Sores. So sores are also called ulcers or wounds. They can happen anywhere on the feet, ankle, or legs. Okay, you don't have to tell me if you've had one, but who knows someone that's had one or has seen a sore on the foot before? Some people have seen them. Now, for you that have seen them, this is kind of a hard question. Usually, for a sore to happen, something happens beforehand. Any idea of what kind of leads to a sore?
Pressure, injury.
An injury?
Pressure.
Pressure?
I have two
You have two.
brothers, not myself.
Okay.
One had a sore,
A sore?
it was like a blister,
Okay.
and it burst. And when it burst, the infection went out through his body.
Up through his leg and through his body.
Yeah.
So a blister is one. How about the other one?
That's when they had to have a total amputate
Yep.
because he wasn't taking care of himself.
And that's what we want to avoid, is preventing amputations. That's why everyone should have an exam like this if you have diabetes. The two big reasons I find that sores begin are because of a blister. Someone wears a new type of shoe, a different type of shoe that they're not used to wearing. It rubs on the top of the foot, and it creates a blister. That blister can get infected. And the second reason is if someone has high pressure, and that develops a callus. And then that callus, if it's not treated, it can develop a sore underneath it. That's called an ulcer. And then if they get infected, or if someone has poor blood flow, it can be a real big problem for us. Okay? Good. Now I'm going to go on to the next system. It's called the review of systems. Do you see where it says review of systems? So review of systems is where we go over all in the body and we ask how she's feeling. Diane, do you have any joint aches or pains? Okay. Do you have any stiffness or weakness? Yes? When you talk to most of my patients, they're all about 70. Everyone says yes to all of these. And no one likes to be called deformed, but there's a question. Any deformities? No one likes to be called deformed, I find. Any skin rashes or nail changes? Any dryness? Any numbness or tingling in your feet? Okay. And any coldness in your feet? Okay. Why do I ask about numbness or tingling? Good. Either poor circulation or neuropathy. Those are the two conditions that maybe have numbness or tingling in the feet. Now, vascular is circulation. Anyone know what the word, it's a big word, claudication means? I'll explain. I never ask someone if they have claudication. What I ask is, can you walk a couple of blocks, or do you have to stop walking to rest a little bit? You can walk. If someone can walk 2 or 3 blocks, that means the circulation is probably okay. There's some patients, they have something called claudication, which means they walk about a half a block or a block, and then they have to stop because they have cramping in the back of their legs. They wait for about 30 seconds, then they can walk another block.
That's me.
Then they have to stop.
How about if you're sleeping in bed?
That's another type, rest pain on here. If you look, it's claudication. And so rest pain can sometimes be due to circulation, but sometimes it can also be due to some other problems like the restless leg syndrome and neuropathy. There's other conditions. But if someone has, every time they walk a block they have to stop, that's pretty common to have, it's called claudication. And I'll explain what happens. What happens, in your legs, you have blood that goes down to your legs. Okay? If there's some clogging in the arteries, and you walk about a block, you need more blood for those muscles to work. If you don't have enough blood, it says, whoa, stop, it's hurting, because you don't have enough blood to feed the muscles. So that's what claudication means, it's just not enough blood flow. Do you have any swelling? No swelling? Now, why would I ask about swelling? Why is swelling important?
Builds up fluids.
It can build up fluids. They may have a heart problem that may have to be treated. Also, if they have a lot of swelling in the legs especially, if you get a lot of swelling for a long period of time, you can create a sore on the inside of the leg. It's called venous stasis ulcer. It's a wound caused by a lot of swelling. If someone has swelling, the first line of defense is what? Elevating your foot. If that doesn't work, the second line of defense is something I know that everyone loves to wear. Who loves compression stockings? I tell compression stockings to most of my patients, they want to kick me out of the room because they're hard to put on. I'll give you 2 tips. 1, put them on before you get out of bed. And number 2, get some dish gloves, some of the plastic gloves to help you put them on. Those are the best way to get them on because they're real hard to get on. And once you get up and if you try to put them on, Forget about it. There's no way you can do it. So for compression stocking, there's a couple times to stop the circulation. Actually, it's the contrary. It's the opposite. In your leg, you have two different circulation systems. You have arteries and veins. Everyone knows that the arteries bring the blood down. The veins bring the blood up. With the veins, there are veins on the outside and veins on the inside. What happens with swelling is that the veins fill up more on the outside, and that's where you can get the varicose veins. And it's having a hard time pushing the blood back up. Because in the veins, there are these little things that kind of open and close as the blood pushes up. So as your muscle contracts, it opens, lets the blood go up, and then it stops it. Well, if these aren't held in the proper position, they're kind of faulty, and they just stay open all the time. And that's where the swelling stays there. So you need to put compression to help them work better. It actually helps the pump work better, the pump that's in the muscle in the back of your leg. So it doesn't stop. They're not that tight. I agree with you. For example, if you put something really, really tight and it makes the toes blue, that's really bad. But when you put compression, there's different levels of compression. We call it the millimeters of mercury. So for example, 20 to 30 millimeters of mercury are the ones you buy over the counter at CVS or Walgreens, and those are easier to put on. If you go to 30 to 40 or 40 to 50, they're harder to get on, but they offer more compression. And there's different levels. Some go up to the knee, some go above the knee, some go all the way up. So there's different types of compression stockings. Next, we're going to move to the endocrine system. Okay, endocrine. Polyuria, polydipsia, and polyphagia. Those are big words. I never ask that to patients. So what I ask the patients is, do you have to pee a lot? Are you drinking a lot, or are you eating a lot? Everyone eats a lot, but for this, I'll just say no. Okay. And then, do you have any eye problems? Any retinopathy? Nope. And any kidney problems?
Degeneration.
Macular degeneration. A lot of other ones. Now we're going to get on to the physical exam. This is the meat and potatoes of the exam. Okay. So we're going to start by looking at the foot. So I want you to just stand up for me. And so we're all going to look at her beautiful feet. Okay? And then what I look for on the first box, it says, is there any digital deformities? Okay? So what I tend to look for are curved toes that are called hammer toes, or bumps on the side that are called bunions. So with her foot, I really don't see anything. I don't see any problem with her toes. Okay? So everything looks good. You can have a seat. I'm going to have you put your feet right up here. Now what I'm going to look for is equinus. What equinus means is there a tight heel cord. So I'm going to bring her foot forward, and if I can get her foot past 90 degrees, that means she doesn't have a tight heel cord. If she has a very tight heel cord, that would make her more predisposed to developing a callus or a sore on the bottom of the foot. So her Achilles tendon is good. Then I also look for something here, it's called plantar flex metatarsals. What that means is one of the bones in the front of the foot, if the bone is further down than the other bones. Do you see that? If it's further down, it could develop into a callus, and then develop into a sore. So I look, and on the bottom, I don't see any plantar flex metatarsals at all. Okay? I look if there's any shark toe deformities. Shark toe, what that means is that you're walking on your foot, and it breaks the foot. I don't know if you've ever seen anyone, but they have a reverse arch. Instead of the arch being like this, the arch is like this on their foot. It's kind of collapsed. It looks like a rocker bottom. And that happens due to a condition called Charcot deformity. It happens in people with diabetes. She doesn't have that. Then I look if there's any previous amputations. That's an easy one. Everyone can come and say, and if you have all 10 of them, there hasn't been any amputations. The next step of the exam is I do something called a pressure stat. So I'm going to actually have her stand and put one foot on each of these, on the right, and then on the left. And then what you can do is you can step off now. And this is called a pressure stat. Do a pressure stat to see if there's any areas of high pressure on the bottom of the foot. I don't know if you remember, I think there were some shoe stores back in the past that used to do this. But it gives an exact impression of the bottom of her foot. Now, why do you think that this is important? The black is the area of high pressure. If she had a lot of black on an area, such as the ones on the back, I'll pass this around, and I'll give you a copy of this after for the television. But areas of high pressure could represent what? risk for developing a callus or a sore. That's why it's important to look at the bottom to see if she has any risk factors. Based on her foot, she doesn't have any. And I'll pass this around so you can pass that around to everyone to look at it. So the pressure stat looked normal. And then I also look at her arch of her foot. Is it a flat foot, normal arch, or a high arch? And she had a normal, Diane had a normal arch. Next, I look at the skin. That's the next. The dermatological means skin. Put your foot up here again. The first thing I look is for Tinea Pedis. Do you guys know what Tinea Pedis is? Have you ever heard of athlete's foot? Yes. That's what Tinea Pedis is. It's just a technical term for athlete's foot. And I don't see any athlete's foot. I look for xerosis. Any idea what xerosis is? Nope. Anyone heard of dry skin? I don't know why they put the hard words on here, but xerosis, there's no xerosis. A skin fissure. All that means if there's have you ever had a really dry heel in the wintertime? And it gets a cut, that's called a fissure. That can be dangerous. So I look at her heels and I don't see any skin fissures. Her feet are wonderful. An ulcer is like a sore or a wound. Once again, I don't see any ulcers. Gangrene. You'd be able to see that. Gangrene is caused by what? Who knows? Infection? Not initially. Poor circulation. Good job. Look at my other gift here. Congratulations. So poor circulation causes gangrene. And gangrene, it doesn't turn green, it usually turns black. Okay. I don't see any of that. Then I also I ask the patient, have you ever had an infection before in your foot? You have had a foot infection. Why do I want to ask about a foot infection? It might come back. The infection might have gone really deep into the bone. So those are all concerns that I need to know. If she's previously had a sore here that's healed, she's at much greater risk of developing another one. Then I also look for the toenails. I look at, who knows what onychomycosis is? How about toenail fungus? Heard of that? So when I look at the thickening, her toenails look like a normal thickness. Okay? Maybe there's one that's a little bit thicker, but that's the one she dropped a can on. So it could have been just that. So I'll just mark one here. And then I also look at between the toes. Why is it important to look between the toes? There can be cracking, dryness, or wetness. If it's very wet or damp, it can get a little cut, and that can create a sore. Very, very common. Now, quick tip. If you put lotion on your feet, should you put it between your toes? No. Because it can keep it too damp in between there. So don't put it between your toes. And then I also feel the temperature. And if the temperature feels the same, that's normal. What happens if one of the feet is a lot warmer than the other? It could show circulation. It could show, but I'm more concerned about something else. If one foot is really, really red and hot, and infection. So that's why I also feel the temperature on both. So we finished side one. So next what I'm going to do is I'm going to check. I have a little thing I carry with me. This is my handy dandy piece of plastic. This is how I check the sensation of my patients. Has anyone ever seen one of these before?
Yeah.
No? If you got bad eyes, you probably don't see anything except this little white card. What this is a little piece of plastic, and it bends. This is the most important tool to determine if you have neuropathy, if you have poor feeling in the feet. So what I normally do is I have my patient close their eyes, and I'd like you to tell me yes every time you can feel it. Just say yes. You don't have to tell me where, just say yes. Okay. So was her feeling good or bad? Good. It was excellent. It was excellent. Did you know there's a lot of people probably here that if I poke you, you won't be able to tell this at all?
Yeah.
That's called neuropathy. Why is that something dangerous? Why? Hey, if you step on something and you don't feel it, you could step on a rock. There could be a rock in your shoe. There could be a rock at home. There could be a kid's toy. You know, any number of things, but you wouldn't feel it. So they really don't have pain. Very similar. I don't know if you've heard of a disease that used to be around more frequently. It's called leprosy. Now, it's not the same. I don't want you to think it's the same in any way. The only thing is, with leprosy, they could cut themselves and not know it, and it's the same thing with your feet. If you have neuropathy, You could cut yourself and you may not know it. So that's something very important. Go ahead.
How do you fix that?
That's a very good question.
Yeah.
How can you fix neuropathy? As of now, the best thing you can do to help reverse it is by taking proper vitamins. There's some nutritional support. To help with the pain, there are some medications that can help with the pain. But to reverse it, there's not much help with reversing it.
Is it hereditary?
It's usually not hereditary. There are some versions of it that may be due to other causes, but due to diabetes, it's normally not caused by the diabetes.
Yeah.
And having diabetes for prolonged periods of time. Other questions? Neuropathy is a big issue. Neuropathy is challenging, and since we can't reverse it, what we do is we try to prevent any of the complications. That's why a lot of the patients that see us every 2 or 3 months, it's not just to trim the toenails. It's to make sure that they don't have any cuts or sores that they don't know about. Because a lot of times people have wounds or sores in their feet, and they don't hurt them. You know how they usually tell there's a problem? Once they get an infection. And then their blood sugar goes up and they feel very sick, and then that's when they look at their foot. Because a lot of times you have poor eyesight as well. So you can't see your foot, you can't see the wounds, you don't know what's happening. So, but your feeling is excellent. Now we're going to move on to the circulation exam. It's called vascular exam on the right-hand side. On your foot, there's 2 main arteries that I want you to be able to look at and feel. The first artery is on the top of the foot. It's called the Dorsalis Pedis. And it's between the first and second toe. And if you put your hand up there, you should be able to feel the pulse, which I can feel. And the other one is back behind the ankle. It's the posterior tibial artery. And I can feel both of them. So it's very important. So her arteries are excellent. And then I do something else. A good way of telling how the blood flow is by just touching the tip of the toe. You see how it's red? I touch the tip, and then I let go. It becomes white, and then it becomes red. And you count the number of seconds. 1, 2, 3. And usually, if it gets white within 3 seconds, 1, 2, 3, the blood flow is normal. If, when I push down here, it takes 10 seconds, then the blood flow, there might be a problem with circulation. Okay? Just an easy test, just pushing the tip of the toe. And then I also, so yours is normal. And then I also look at the swelling, if there's any swelling in the ankles. So I look at the ankles to see if there's any swelling or swelling in the foot. She doesn't have any. But some people, they have a lot of swelling, and I can actually push down into the skin, and then I also count the number of seconds it takes for the skin to become normal. So swelling is something that's very common as well. So that concludes the physical exam portion of the patient's exam. Now what I do next is I actually do a shoe or footwear evaluation. Do you know why I do a shoe evaluation? How come? It could be causing. It could create rubbing or callousing or sores. What else? What happens if they have a penny or a rock or something in their shoe they don't know about? It could be a problem due to the neuropathy. I have a story of a patient that he actually liked to golf. And every time he went to golf, he took off his normal shoes, put on his golf shoes, and went golfing. Well, one day, when he came back from golfing, his socks and shoes were all bloody. He didn't know why. He didn't feel it because he had neuropathy. Any idea why? He didn't have a rock. Well, how many of you, whenever you take off your shoes and socks, you take the sock and shove it in the front of the shoe?
Oh, yeah.
That's what he did. The previous time golfing, he shoved the white sock in the front of the shoe. Then when he put the shoe on, he didn't notice it. And he didn't have any feeling, so his toes were cramped the whole time, and he developed a sore. So you have to be very careful. That's why we look at people's shoes to see if they're appropriate. So she has sneakers, an athletic sneaker. They look like they're a good fit. I make sure they're the right size. In my office, I tend to have a measuring device, and I measure people's feet, and I measure their shoe. Any idea why I do that? How many, I'm not going to pick on anyone here, but I'm looking at the ladies. How many ladies have said, you know, when I was 20, I was a size 7, and now I'm 60, and what? I'm still a size 7. They don't want to believe that their feet get larger. But everyone knows after you have children, and as you get older, your feet get larger. And a lot of my lady patients especially, they say, no, I'm going to always wear this shoe. And that shoe is what's causing the problem. So I measure, for a lot, not picking on any ladies, but most people wear shoes that are too small, especially with diabetes and neuropathy, because they don't feel their feet.
I walk, so when you walk, your foot goes forward.
It pushes
So
forward.
I get just
A little bit larger.
to walk.
Perfect. So you have to be really careful with your shoes. Now the next portion here is called the risk stratification. So I do this to kind of evaluate how often she needs to be seen. If she's had an ulcer or an amputation, I should see that patient every couple of months. If someone has neuropathy and poor blood flow, PVD is poor blood flow, I might see them 4 times a year. If someone has just neuropathy, I might see them twice a year and do this exam. But in your case, if you only have diabetes and great feet, I'll just see you once a year to do this type of an exam. Okay? And then a big portion of this exam is education. And there's a big portion where I review the risks of diabetes, we talked about the dangers of neuropathy, which we talked about, the risks of high pressure, which we talked about, the care instructions, how to do a self-exam, medications. A lot of this exam, all the educational portion, I've done throughout this exam. But I just want to emphasize to you the real importance of doing an exam like this for you. I do have some resources that I offer to my patients. So since she is hypothetically my patient, I usually do prescriptions. It might be for a diabetic shoe, if they qualify. In case you don't know, everyone with diabetes, the majority of those people can qualify for a pair of diabetic shoes through your insurance. So that's something that if you're not getting, you should do. Other people, they may need, if they have some poor blood flow, I may have to send them to a circulation doctor. So it's very important. Maybe I'll do a referral, as it says referral. Then I'll do a shoe prescription, and then I'll say the next diabetic foot exam is in 1 year. And then for her, if she had poor blood flow, I may even do some vascular testing or some circulation testing in the office. That's something that we can do. I put my signature, and I send a copy of this to her primary care. And then as she leaves, all my patients, I give them a copy of this foot pressure stat, because 2 reasons. It has educational material in the back of it, and I tell them to put it up on the refrigerator. Because it looks nice. So this is for you. And then I also have for her, this is a booklet that I put together. And I give this to all my diabetic patients. It's called A Healthcare Guide to Diabetes in Your Feet. And it explains the 3 ways to prevent a wound, the 8 steps to a comprehensive foot exam that I just did, the 4 serious foot care mistakes diabetics make, and then the 4 questions to ask your podiatrist. Okay? So I have a couple of copies of these there, but I also have this available on my website. We'll put it on for the TV. It's at drpelto.com. There's a little thing where you put your email, and I'll send you all the tips that you need for diabetes. So I'll give this. If you want to put your name and email,
Sure.
we pretty much take all insurances.
Take Reliance.
We take Reliance. And my card's up there if anyone wants to ask any questions. So why would the front of the legs be red?
Chest infection.
Infection is one. She could have circulation problems. And there are a couple of other dermatitis types of problems that people can get. They can get little wounds on the front of their legs due to, one technical name is necrobiosis lipoidica, which is a big term for someone that can develop sores in the front part of their legs. So they should probably be seen by a dermatologist. Yeah, the question I ask people is I ask, well, if you have your primary care and you have diabetes, do they ever send you to see an eye doctor?
No, I go every
Yeah,
2 years.
usually you see an eye doctor for the diabetes to look at your eyes. Well, it's the same thing about your feet. Most people should probably see a foot doctor just to evaluate for an evaluation. So the question is, do I only do diabetic feet? No, I actually treat everything. I treat bunions, hammer toes, ingrown toenails, warts, everything that needs to be treated with these. They asked me to do a talk today on diabetes.
Where's your office?
It's on Lincoln Street, right by Hanneman Hospital, a couple doors down. The old nursing home. There's an old $2.99 home.
Oh, yeah.
Well, let's give a big hand to our guest, Diane.
face mask down. About the chest guard, it looks loose. Is it loose? Okay, here comes the heat.
You don't have to be perfect to be a perfect parent. There are thousands of teens in foster care who would love to put up with you.
Somebody took it away from me in the blink of an eye. In less than a month, this woman destroyed what I had worked for 15 years.
I mean, your credit score is basically all you have.
I was mugged, they got my information.
It can really negatively affect your life.
Then they went off with the information and basically became me.
I feel it's a loss of control that someone's out there pretending to be you and doing things in your name that can come back to haunt you.
Somebody was using my name and all my personal data.
They'd done it all.
I just didn't even know where to start.
They had a long record.
It's a terrible feeling.
Identity theft. It happens when your personal information is stolen and used without your knowledge. It's a serious crime that can cost you time and money, ruin your credit, and destroy your good name.
When I was a victim of identity theft, my mail had been stolen.
I was shopping at a grocery store and someone took my wallet.
I think I made a purchase and they stole all my debit card information.
My briefcase had been tampered with, and when I looked in it, I saw that my passport and my driver's license, which I had in there, had been taken.
Identity theft happens when someone takes information about you and then uses it to commit fraud.
Identity theft is very serious.
We know that identity fraud in its various forms has affected 10 million people in any given year. And what that means in dollars is that it's a loss to businesses of about $50 billion. On top of that, victims of identity theft have spent $5 billion trying to undo this harm.
Everyone needs to be conscious that identity theft is real.
When you get news that your identity has been potentially stolen, it's sort of this open-ended problem that has occurred, and you don't know what's going to come of it.
No one's immune, which isn't to say that we're powerless. There's a lot we can do to deter, detect, and defend ourselves.
My identity was stolen when I was mugged. It is pretty traumatic, especially how it happened to me. They got my information and it happened. Then they went off with the information and basically became me when they went to charging items in stores.
Identity thieves can only take advantage of you if you give them information or if they obtain information about you. So what you want to do is take steps to make it less likely that your information falls into the wrong hands. There are many ways that you can do that. And the first is to stop and look in your wallet. What are you carrying around? And if you lose your wallet, are you giving somebody else an opportunity to commit identity theft? So avoid carrying around any identification that has your social security number on it in your wallet, because that can be used very easily and efficiently by identity thieves.
They could have your name, they could have your birth date, but if they don't have your social security number, they're not going to get very far. But all they really need is a social security number, and they can misspell your name and still get credit. The only place that social security card number should be is in your head and protected somewhere at home where you keep your other valuables.
And if someone asks you to provide a social security number, ask them why they need it, how they're going to keep it, how they're going to safeguard it, because you don't want that number to fall into the wrong hands.
I had an incident that I thought was a valid reason to give out information until they asked for my social security number. I went as far as the first 3 digits. I thought, gee, they don't need that. Then I hung up.
This is a crime. You have to think when you're at home, protect your identity. Don't leave around your personal documents, your date of birth. Somebody could come into your home and have immediate access to that information.
You also have to be careful about your trash. Now, a lot of people routinely receive things in the mail, maybe bank statements, credit card statements, or health insurance forms, and if they don't need them, they just throw them away in the trash. They shouldn't do that. Everyone should invest in a shredder. So before they dispose of these critical documents, you shred them. Identity thieves, don't worry about getting their hands dirty. They will go through your trash to retrieve these documents. They go where the information is. They'll steal your mail, they will steal your trash, they'll steal your wallet, and that's how they get information about you.
Deter identity theft. Protect your social security number. Shred financial documents and paperwork with any personal information before you throw them out. Never give out personal information on the phone or internet unless you know who you are dealing with.
My name is Nicole M. Robinson. The woman who stole my identity, her name is Nicole A. Robinson. She stole my information from the pharmaceutical company that she works for. After this happened, it devastated my financial life. I ordered my credit reports, and I received a credit report in the mail that was 54 pages long, It had over 170 accounts. 140 of them were in collections. It had 42 different names and 65 different addresses on it. Not only was somebody else reaping the benefits of my good credit, I could no longer have access to my own good credit. And I cried. I cried every day for 3 months.
On top of the financial and the time that people spend in resolving these issues, it's an emotional burden on victims.
My life before the identity theft case was wonderful. In less than a month, this woman destroyed what I had worked for 15 years. She got my life.
If an identity thief uses, for example, your social security number and applies for new credit in your name, as opposed to raiding an existing account, there may be no way for you to know about it unless you've checked your credit report and you see that a new account that you didn't even know about has been opened in your name. That's why it's very important to monitor your credit report regularly.
Detect identity theft. Check your credit report at annualcreditreport.com. Federal law gives you the right to a free credit report every year from the 3 national consumer reporting companies. Review your financial accounts regularly. Look for charges you did not make.
When someone realizes that they're a victim of identity theft, it's like getting a kick in the gut. You know, you feel paralyzed for a moment, but it's really essential for victims to move quickly and deliberately in starting to resolve the problems that arise from identity theft.
I did what everybody knows to do, and that's call your credit card companies and cancel your credit cards. However, that's not enough. There was one major bit of information I did not have, and that was to call the 3 major credit bureaus. And I did not do that, and what happened was this person then went back. She was able to reopen the credit cards that I canceled. She was also able to open new credit cards in my name.
If you find you've become a victim of identity theft, the first thing you need to do is contact one of the 3 major credit reporting agencies and have them put a fraud alert on your file.
You got to take it seriously. You even suspect it, you got to put fraud alerts on. You got to take the steps to protect yourself, and you got to inform yourself about what to do so that when it does happen to you, you can do it quickly because time is critical.
You next want to contact each of the creditors or other institutions where your information has been misused. Then you follow up in writing and dispute these accounts and get a letter from them resolving these disputed fraudulent accounts.
The FTC has an affidavit, which in my case I used, to write out your explanation of what happened that you can then use to submit to creditors trying to collect on fraudulent accounts. When you're trying to tell them, look, my identity was stolen, it helps prove it to them.
You next want to contact your local police department, report the crime, and get a copy of the police report.
You should contact the police immediately, because otherwise you have no proof that there was a crime.
It's very important that you report it to the police because there are certain agencies that you need or we recommend that you contact, and they're probably going to refer you back to the police department to see if you have a police report or not.
And finally, you need to contact the Federal Trade Commission online at ftc.gov/ID theft or call us toll-free at 877-ID-THEFT to report this to us.
Defend against identity theft. Call the 3 credit reporting companies and place a fraud alert on your credit report. Then ask for the free credit report you're entitled to. Close any accounts that you suspect have been tampered with or opened fraudulently. Start by calling the security or fraud department of each company. Follow up in writing and include copies of supporting documents. File a police report. Contact the FTC. Your information also helps law enforcement officials across the country to track down and stop ID thieves.
Let's treat our personal information as we would our cash. Let's safeguard it, whether we're at home, whether it's in our purse or our wallet, or at our office.
Your personal information is cash, and in the wrong hands, it can destroy your life.
The FTC plays a central role in helping victims avoid and recover from identity theft. So we have developed substantial consumer education material that's available on our website at ftc.gov/ID theft.
Identity theft is serious, but even if your identity has been stolen and there has been, fraudulent accounts opening your name, you can defend yourself and get those resolved in your favor.
There are times when you just do not want to finish and you just want to say, forget it, I can't do this anymore. But you have to find that way inside of you to just keep going, because this is something that if you don't clear, it definitely affects the rest of your life.
What I want is for us to create a culture of security for our personal information. so that this crime in the future will be diminished greatly.
We are all trying to create change. We work on a daily basis to create change and to make a difference for animals, for life. This is about animals in general, and it is very unique to have a large animal care facility along with a small animal shelter. I think that our goals are the same.
Oh, I know you're a good girl, aren't you?
Anytime you're dealing with animals in a shelter situation, it's personal.
Join your girlfriend.
These creatures have been creatures of nobility to us. They're so graceful, they're so pretty. And everyone who sees a horse running through a field for the first time or the 100th time feels the same thing. Isn't that beautiful? That's such a noble creature.
"12 to base, FYI, I found them." There's animals in distress out there. There's animals that need people like us. A lot of times, we're the animal's last chance. I mean, if it weren't for the MSPCA law enforcement officers and the MSPCA in general, a lot of animals would suffer. Back and see if you can get any more info from that.
On that left front, and he's already
I really love to work in emergency critical care medicine. I never know what's going to blast through the doors at any minute. I never know what's already in the hospital that's going to change dramatically that needs my attention. And it's a job where little things that you do every day make a real big difference.
Here we go.
Everyone's going to go, oh, and all your babies. Yeah.
For the most part, shelter staff people come in the morning and they work hard physically. They scrub kennels, they clean cages, they walk dogs.
Okay, Callie, are you all set? We've got a flood of people.
We open our doors and we are ready to take in more animals, relationships that have failed, stray animals that have nowhere else to go. At the same time, we're sending some animals home. We're doing adoptions. We're trying to focus in on doing some good, permanent, responsible pet adoptions. Some of the rewards, some of the wonderful things that happen in a shelter are making sure that that animal has something soft to lay on, making sure that he or she has fresh water and a fresh bowl of food and is well fed. It's meeting the basic needs of that animal on a daily basis. And for any one of us that works in a shelter, that can be incredibly rewarding.
You're all set. You're going home.
No matter how bad the case is when it comes in, it's in their eyes, and we can get it out of their eyes. Sometimes the eyes are dulled over, but we can see it, and we can get them back. Our job is to take that animal, bring him back to the nobility he once had. That's what makes us go. That's what makes me go personally, and I think that's what makes my staff go.
Coco, come on. Stop. Hey, you want to hold that dog, please, sir?
Over the past 2 years that I've been working with not only the gang unit, but also Boston Police District 11 out of Dorchester, the task force, I've come to learn that they also see animals as victims, just as they would a domestic violence victim or a child abuse victim. Right now, pit bulls are basically like a fad. You know, they're the in thing. It's a status symbol. It's, you know, kids walk down the street with their pits. Nobody messes with them. You know, nobody gives them any trouble. I'm trying to reach everybody, you know, but my biggest thing is trying to reach kids. My goal is to get as many children as I can to accept that animals are living creatures with feelings and deserve the right to live without being abused, being treated as a piece of property.
Big part of what I do is overseeing what's going on in the emergency room when I am seeing patients when I'm on clinics. That means that I'm triaging whatever cases come in the door to help decide who gets seen in what order. I'm also overseeing what all of the interns who are working with me are doing. Are they doing okay with working their cases up and getting them stabilized? Do you have a lateral from originally? We have, in one sense, the luxury of getting really, really attached to our patients. All of us, everyone who works here, no matter what they do, we all develop favorites. We really develop personal relationships with different animals that are in the hospital. And that's incredibly enriching to our day-to-day life here and makes it all worthwhile. But on the other hand, when they're not doing well, or they're being euthanized, or they're dying, it's so much harder than being emotionally distant. But we can't be. We'd never do this if we were emotionally distant.
Hi, Zeus. This is kind of shocky, so we need to put a catheter and get some fluids in here.
A lot of it is my relationships with the people that I work with, and I think when you work in this kind of job, in this kind of environment, you do develop really strong feelings about the people you work with. We feel like a MASH crew at night. We feel like we're the only ones out there sometimes. All of the people that I work with, the nursing staff, the support staff, everybody that works here, we share something.
That's what helps people get through the day. Giving the cat a hug, giving the rabbit a hug as you're placing it into a cage. That interaction with every one of those lives that comes into the shelter. I mean, that's why we're here. That's what this is all about.
I see some really unbelievable stuff, and I see case after case of people willing to do anything that they could possibly do. I have seen people do incredible things financially because of how deep their love for their pets are. And I never cease to be amazed at how important these animals are in their lives, and makes me feel like what I do is really important.
You see a lot of things that people wouldn't even imagine that could happen. Some of the cases that I've worked in have affected me, that they're going to stay with me forever. It's hard, you know, I mean, going home at night thinking about the dog I left in JP today. Is he going to be brought in the house tonight? Is that food that was on the ground, is that all the food he's going to get until tomorrow or the next day?
You're a baby. All of us that are working here work here really and truly because we love the animals and we want to provide the best care for them possible. That's what keeps us up at night. That's what makes us never really leave, even when we leave at the end of the day.
We all care deeply about what we do, and we'll get up tomorrow morning and do it all over again.
I think of the thousands of lives that come into our shelters every year, and each one is individual and each one has a story, and it's all about respect for that life and a commitment to that life. As painful as this job can be, there truly is not a night that any of us don't go home and feel really good about what we did that day. We're making a difference. We may have helped one animal. We may have made one animal more comfortable, got one animal out of a bad environment. You want so bad to make it better that you're back every day doing the little things, and sometimes big things come out of that.